Okay, real quick, precision medicine. This is a great PR campaign that is way ahead of the science. And so without precision medicine, which is how the vast majority of myeloma patients and other cancer patients are treated, they do not have sequencing performed or treatment tailored to their DNA. And hence, you get treatment, some benefit, some don't, and a bunch of them have adverse effects or side effects from the treatment. And you really don't know which. And the reason is that of those 2 to 6 tribes with different sensitivities to different drugs, we try to give you a combination of drugs that works for the majority. In myeloma, it is both an incomplete response, and in the majority of patients, not every tribe responds. So that's why we're not curing patients with myeloma, is that we have an incomplete killing of the tribes, and even there, a partial killing of the ones that are sensitive. On the right-hand side is a little bit about where we need to be able to sequence and understand the function of every patient's myeloma and give them targeted therapy that will allow every tribe to be targeted effectively and killed, and hence every patient to be cured. How close are we getting? We're getting a little closer. So on the left-hand side are a number of mutations that are all difficult to understand. The one that comes up to me most often is the deletion of chromosome 17p. The short arm of chromosome 17p has a very important gene on it that leads to patients having high risk. All these other alterations can be targeted through a number of different drugs and classes of drugs that may help, because in patients with relapse disease, there's one big clone causing the trouble, and hence you could use one drug to target that one clone and have some pretty significant success. So this has been part of a proposed trial looking at early relapse myeloma, where patients would undergo genomic profiling, which means for you a painful bone marrow biopsy where we sequence the DNA of the myeloma cells, and look for specific mutations in the different squares on the top row, and then each of these mutations would be targeted by specific drugs for that mutation. And a little bit of yin-yang is that they would get a targeted drug, but they would also get standard therapy for their myeloma, thus allowing the majority of patients, we hope, to get a response, or more likely to get a response to attack their myeloma biology with a specific targeted therapy for a genetic mutation we've identified in that particular patient. And we hope that that combination, attacking the biology as well as the DNA, will lead to more success. I'd like to say, though, that the 17p right here, I had my first 2 patients have that access to that drug and had a fabulous response. I haven't had a fabulous response in the 17p patient in I don't know how long. So I'm really excited about this. So please don't take my casual critique of precision medicine and the hype, meaning I don't believe that this is the right way to go. I do believe we need to tailor treatment to specific patients.